Shanthosh, thank you for joining me again to talk through another cardiac ischemia case. So Shanthosh is one of our cardiologists who works here and one of our PhD students. Thanks again for doing this.
Yeah, no, thanks for having me.
Pleasure. I know you don't really like it. Thanks for coming.
That's not true.
So this is the story of a 70-year-old man who blacked out in the shower. And he'd been experiencing some heavy feelings of what he thought was heartburn sensations over the last 2 weeks. He'd been feeling a bit unwell earlier on in that day, and he'd had a pre-syncopal event, and then he'd had the syncopal event in the shower with his chest tightness, called an ambulance, and was brought into the ED. I'd like to start off, if I can, by just showing you the ECG, and if you don't mind just helping us out to have a go through this, and then we'll go through the echo.
Yeah. So the ECG, the first thing I note that it's in sinus rhythm, but it's got a prolonged PR interval, so it's in first degree heart block. He's got ST elevation in the inferior leads, particularly in 2, 3, and AVF. The most important thing is that you always have to compare the elevation to the preceding QRS complex. So that he had chest pain?
Yeah, he had chest pain. He had chest pain that was occurring after his syncopal episode, yeah.
Yeah, right. So this, I would call the cath lab for this gentleman.
Now, he was also a little bit hypotensive, right? And our classic teaching when we're dealing with patients who are hypotensive with right coronary ischemia is we give these guys fluids, right?
Yeah.
So I was wondering if I can quickly just show you a pretty cool new bit of software that we've found. This is called Harvey Online, and it's an amazing bit of software that you can buy with a subscription. It's not too much. And what we can see here is I've got in this top left corner here, this is the hemodynamic curve or the pressure volume loop for the patient's right ventricle, and then the left ventricle on the right side. This marker here, this top line here, is a marker of contractility. That marker there is because it's the end systolic elastance curve, or the pressure volume relationship at end systole. This curve at the bottom is the pressure volume relationship at end diastole, and is a marker of compliance. When you have a heart attack, you therefore start to impair your right ventricle elastance, or the right ventricle marker of contractility. So what I'm going to do here is I'm just going to reduce this right ventricle marker of contractility, and you'll see that, as that contractility reduces, that reduces your stroke volume that you can see over here on the right. Don't know if you saw that. As I reduce that contractility, the stroke volume goes down. Yeah. So the reason why these guys like fluid is then if I give this patient fluid that I can do up here, so let's give him, and what would you standardly give?
At least I'll start off with a liter, or sometimes these guys will need, some 2, even 3 liters sometimes. They're really preload dependent.
How about I give him a litre and a half and just look what happens to the stroke volume, right? Yeah. And you can see that they're on the left ventricle hemodynamic loops as well. So I think this is hopefully quite elegantly demonstrates why these patients need fluid, and this is not the same as someone who's got pulmonary hypertension, for example, and a blown out right ventricle that way, who's got worsening compliance. Yeah. And maybe we'll show that in another case.
Yeah, this is really cool.
I love it. I think that's pretty cool. Okay, let's have a look at the echo.
Before we even go to the echo or the angiogram, I mean, in terms of the history with an inferior infarct, the thing that I'd be most worried about in a gentleman who's had a syncopal episode is, have they gone into heart block? Nice. Inferior infarcts or right coronary arteries, they commonly go into heart block, and they can be sick. These guys will need, sometimes temporary pacing wires, or more support, particularly from the intensive care staff while we do the cases. So this, it's all hands on deck sometimes in these patients.
Very nice. Okay, well, let's have a look at the echo. So I'll start off with our parasternal long axis view, and the walls that I can see in my parasternal long axis view. From the septum wall, I'm looking at my anteroseptal wall, and I can see my base and my mid-ventricle segments. And then on the other side, I can see my infralateral, and that's the base and the mid walls. Yeah. And with right coronary ischemia, I know we can get differences in coronary artery territory, but there's a beautiful diagram that we know from the American Society of Echo Guidelines, which shows that when we're thinking about right coronary ischemia, classically we're looking at those inferior, infralateral and infraseptal walls that would be down of course it can be variable.
100%.
Fantastic. Okay, so what do you think about this view?
It's slightly down, but I'll definitely have another look at it. It looks like the anterior wall or the angioceptor wall is contracting well. So I'll be looking at your 4 and your 2 chamber views. And
fantastic. And the short axis I
short
like
axis
as well.
will be
we'll use
really
other
helpful.
views, that standard idea that if you've got a regional wall motion abnormality or any abnormality in one plane, go and look at it in others, right?
This is great. You've got your short axis view, and what you can see is in the inferior and the posterior wall segments, it's hyperkinetic in comparison to the anterior and the lateral walls.
Yeah.
And this really fits with the history of the ECG, and I'm really curious to see, as a cardiologist, I'm really curious to see what the angiogram shows. Yeah.
Yeah. And I know it's not often talked about, but I think can I persuade you that I think that sort of inferior portion of that right ventricle is also not moving as much as the anterior. We don't talk about regional wall motion abnormalities a lot in the right ventricle.
Yeah.
But you can understand why this guy would be hypotensive, because I think half 100%. Of the ventricle, we can't see it brilliantly, but it's not working very well. We've got our apical 4-chamber view here, so we're looking here at our we're looking here at our anterolateral and inferoseptal walls.
And it looks like they're coming in nicely. So
and they're thickening more than 50%. Yep. Let's have a look at our 2-chamber. And I do think it kind of backs up what we saw on that short axis. I still think that inferior wall, the basal wall, is not moving as well as the anterior and hypokinetic, like you were saying.
So that is a bit more clearer there.
And the 3-chamber,
it's down, right? So
and those basal and mid levels, it's just like the parasternal long that we were looking at. So we're looking there at the inferolateral segments and the anteroseptal
thickening nicely.
And those 2 are down. The last thing that we can see at the end of this, the subcostal views weren't great, so sorry just to skip over those. What we can see down here is the sonographer has done strain analysis here, and I won't go into strain analysis too much more, but you can see that we've got each segment is analysed in a separate manner, and the colours go accordingly with each segment. And you can see here that those areas that we said that were hypokinetic in our assessment of the 2-chamber views, they've got much lower strain. So the higher the strain, the better the contractility. And you can see these curves here for the base, mid, and apical of our inferolateral walls are all lower compared to the anteroseptal, and that's in our 3-chamber view. If I go down to our 4-chamber view, again we're seeing the same. We're not seeing quite as much. I think probably there's not adequate tracking of the bottom one there. But in our inferior views of our
it's down.
It's down as well. So again, that's then shown in what's known as a bullseye plot, and I quite like these bullseye plots where we can see that red is getting towards normal contractility in here, and the pale red, white, and then blue. These are showing reduced function there in the inferior segments, and this is absolutely classic for a right coronary scheme.
This is a great view of just to look at the overall picture of where there's reduced contractility. So this pattern of the bullseye will be in keeping with the right coronary artery territory infarct.
Shall I show you what you really want to see? Which is
100%.
Sure.
So this is an angiogram of this patient. Obviously, this patient was brought up as a STEMI or a TAMI call in whatever day and time it was. You've got what's called a TIG catheter or a Tiger catheter, and the LAD is coming off at top, and the circumflex is coming down. We're just going to be looking at multiple different views. This is actually an interesting picture. What you can see is you've got the LAD at the top, you've got the circumflex that comes down, and you've got the right coronary artery. So there's collateral circulation from the left system to the right. And so what this suggests is that there probably was an element of chronicity. And there may have been a tight lesion that may have just blocked off suddenly.
Got it.
And they've occluded. This is important because it can also tell us what the pathway of the right coronary artery is and how acute this lesion may have been.
So he'd have had chronic disease building up over multiple years, most likely, and then he's reaching to that stage of getting the unstable angina, if you like.
That's exactly right.
When it's becoming critical.
Exactly right.
And the critical stenosis, when you typically see that, is that sort of around about 90% or so?
Yeah, it could be 90, 95. I mean, it's quite interesting as there's an element of ischemic preconditioning. The coronary arteries kind of remodel, or there's angiogenesis, and so you get these collaterals forming to try and compensate for the lack of coronary blood flow. So the LAD is at the top coming down, and the reason why I know it's the LAD, it supplies the apex, it's got the septals perforators which are coming down, and the diagonals to the left-hand side supplying on the lateral wall. There is disease in the LAD, and in the mid segment and also in the distal. You don't worry about the distal, it's too small to stand to do anything about it. The mid segment you may consider to fight another day, but you leave that. That's not your critical lesion, because I know from the ECG the culprit lesion is the inferior or the right coronary artery based on the inferior ECG changes. I also know that based on the echo. So the echo and ECG is quite helpful before the angiogram to say, okay, what is the culprit? Because sometimes you may have multiple lesions. So you may have an LAD which is tight but not critical, or may require intervention, and you've got the right coronary which is also tight and may require intervention. Then you don't know which one is the culprit artery.
But you'd go for the culprit based on the echo, the ECG, and
100%, and that's exactly right. So that's why history and examination is so important for us when it comes down to this. So what you can see is you can see the collaterals forming just there, and that's the right coronary artery filling from the left-hand side. So moving forward, again, the left circumflex, some non-critical disease, but nothing that you'd be worried about at the moment. Here they're going to try and look at the right coronary, and this is quite obvious. You've got a bright occlusion of the right coronary artery, and this is in keeping with what you would expect, or the ECG. So they've come in with now a guiding catheter to help us to wire the lesion. So they've passed the wire through the right coronary artery, and all of this haziness, that's all thrombus, that's all clot.
Right.
So you've
got to be careful every time you're putting the wire through. You're disrupting clot. You could be chucking that downstream and just, brutalizing the distal microcirculation.
Exactly right. Yeah. So you're going to trash that microcirculation, because all that thrombus is going to go downstream. So they've now come in. So there's two ways of treating this. Either you can aspirate. You can balloon initially to try and break up the clot. You can aspirate, but the aspiration of the clot, the evidence is equivocal. So people still do it as clinical practice. Or you can just directly stent and just trap all of that thrombus behind the stent to try and prevent any further distal embolization. And so that's what they're going to do. So this is the stent. They've deployed deployed the stent, and look at that.
Look at that blood flow.
Okay, so what they've done is they've gone directly stented the artery to trap the clot or thrombus behind it, and you know that there's a stent because you can kind of see this meshwork or the scaffolding of the stent there. You've got disease further down, but again, not critical. You've got a bit of disease in the PDA, and again, you'd leave that. You wouldn't mess around with that because that vessel size or diameter is too small, and if you put a small stent in that, it will block off.
Right, okay.
But the main lesion, you've fixed.
Beautiful.
Okay, so they've
done a great job.
That's an amazing job. Yeah. So they've just what they've done is put a stent in, trapped the clot behind it, and left it alone. If you try and meddle around with it at the moment, you'll dislodge the clot, you trash the circulation, microcirculation, and then you get no reflow, and the patient will go.
So leave it as that, and then come back for a stage procedure down the track and look at other areas if you need to.
If you need to.
Awesome. Well, what we've also got is we've got a follow-up echo of this guy that happened a few weeks later. Maybe just have a quick look at that and try and see if there's any changes. Because this is the follow-up echo that was done a few weeks later. I think we're still in the parasternal long axis view. I still think we've got some hypokinesis there in those basal and mid segments of the infralateral wall.
And look at that. Compared to your initial short axis view in the mid segment, when the patient initially had the infarct, you can see that inferior wall is now contracting much better in comparison.
Yeah, and here at the mid-ventricle level, we're definitely seeing better cardiac function in that way. Excellent. Apical forward chamber, same as before. Inferior still got some hypokinesis, but maybe a little bit better than it was before.
Yeah.
Shanthosh, thank you very, very much for your time. That was
You're most welcome.
Awesome. Pleasure.
Thank you.
Bye.